Thank you. In the interest of time, I came because we're running a bit late. So, can I invite here Professor Shalimar, the professor from hepatology and gastroenterology from All India Institute of Medical Sciences in New Delhi, Professor Manoj Kumar, professor and head of hepatology at ILBS, and Professor Sanjeev Sachdev, who is professor and head gastroenterology at the GB Pant Institute of Medical Sciences. And we also have Professor Gaurav Gupta, who flew in today, who is a nephrologist, but also works with Arun, and I requested him to join us for this particular session. And I also would request Dr. Sibal and Dr. Chawla to kindly continue to be with us. So we have a very, very elite and very experienced and knowledgeable panel. Keep writing your questions while I would like to briefly start the discussion. We know that the metabolic fatty liver disease, or MASLD or MAFLD, whatever you may call, is quite common, and the shared pathways, as Arun showed in his beautiful talk, are very common. To just give Delhi people some kind of a feeling, we did a survey 2022 to 23 in the Mohalla clinics, those days Mohalla clinics. Of the 6,700 people, 56% of Delhiites, 1 in 2 had fatty liver. Are you from Delhi? It doesn't worry you? 1 in 2 in Delhi, and 11% of those were not obese, they were lean and thin. And this is based on FibroScan, the next level, not just FIB4 or something else. And same was shown by Dr. Shalimar in his large publication, in which he collected many studies, and he said 38 to 40% of the people in India from different parts have fatty liver or kind of extra fat in the liver. And that means for those who are not really liver people, maybe 5% of the fat in liver is okay, but above 10% it causes worry and insulin resistance. With that in mind, we have few questions, and you can note your questions. I'll be very brief. So may I ask the first question to Dr. Shalimar, who has led that study. MASLD is increasingly described as a systemic metabolic disorder rather than just a liver disease. Do you think the liver should be considered a central driver of the cardiometabolic risk?
So I think that's a very good question. Just before I give an answer to that, so we've done another recent study, which is a Phenome India cohort, which is part of the CSIR IGIB, and in which we've almost done a survey of 8,000 healthy individuals, so-called healthy, whom we are sitting out here. We'll consider ourselves healthy. And again, the prevalence of fatty liver based on FibroScan is again 40%. So, and it's a pan-India study. Or almost like 26 states were involved.
Actually
reaffirms that
40% of Indians means 40 people here would have fatty liver. Don't have to raise hands, but that's okay.
And would agree that I think ours, the population in Delhi is probably more, as shown by your study, sir, also shows it's 56%. I'll say it's even more than that, probably an underestimate of what we really have, and it's a big thing. It's a big numbers which are there. Coming to the point, yes, we've heard in the talk also by Professor Sanyal. Now, in terms of the pathogenesis itself, liver, what classically was shown in that very beautiful study which Professor Sanyal alluded to was how the obesity, then the fatty liver, and then the diabetes appears. So in a sense suggesting that each one of them have linked, and probably it's the pathogenesis also, if we look at, it's the fat, it's the inflammation, and possibly other roles of other things like which we didn't allude in the talk was like, say, microbiome. Lots of other things which come into play, and possibly it's an interplay of things, and liver possibly plays an important role, as we heard. It's in the synthesis of the lipids, where you're looking at the increasing events of coronary events, renal events. So liver is an important player, but again, I'll also emphasize that it's not the only player. We need to look at the human body in totality, and there are other players also. And microbiome also is another upcoming thing which is being looked at as a possible.
So the question should liver be considered the central driver for cardiometabolic risks? Driver.
Yes, yeah, I'll say we have evidence, yes, to state that, but then it's possibly it may not be the only thing. We still are learning a lot, but then yes, evidence suggests possibly it plays an important role. Yes.
From the pediatric perspective, they say that don't give sugar to the kid, and especially till the age of 3 years or so. Do you think we can prevent development of fatty liver in the kids by early understanding of the role of liver and liver fat, Dr. Sibal?
Thank you, Professor Sareen. I think I'd first like to comment on liver being the central organ. You see, for all of us, and at least 6 of us believe that liver is central to everything because, have you anyone out here seen anyone walking without a liver? But you've seen so many people walking around without brains. So we in hepatology believe that liver is central. Now, just going and looking at what Shalimar did with Professor Arora's guidance, we'd studied fatty livers in school children. We looked at 9,000 children. And we were very alarmed to find that overall 24% of children had fatty livers.
Below which age?
They were between 9 and 14.
9 and 14, and you have 24%, and
yeah.
that.
And this included obese and overweight kids, and also normal-looking kids. But when we looked at the obese, it was close to 44%. So the question here is that the beginning of this problem starts in early years, and that's why your question about what can we do at a very early age is extremely important. So some positives, as a pediatrician, I see that the trend to exclusively breastfeed is increasing again, which is fantastic. Exclusive breastfeeding is now again fashionable, which is brilliant. And mothers today are very particular about both containing salt and sugar in the diet, at least till 12 months of age. But I think we perhaps need to be more pragmatic in decreasing the amount of carbohydrate
so
as
we need
kids
to
go
decrease
older.
sugar and fat early enough in life. So the question, sorry to interrupt you, we have someone in the audience who is a next keynote speaker. Jagat, would you like to make a comment on your sugar in the US and the role in the fatty liver? Can you give him a mic? Can you give him a mic, please? He has a seminal new work which may come up sometimes in the future. Jagat?
Yeah, no, I would actually be presenting it during the talk also, and I am not sure about the MASLD so far, and we would certainly be looking into it. But as far as diabetes is concerned, hypertension is concerned, obesity is concerned, and coronary artery disease, MI, stroke, and all are concerned, the children who did not receive sugar in the first 2 years of their life, plus minus intrauterine life also, they did way better 40 years later. And that is the data that are based on the UK Biobank, and it ranges between 28,000 children to about 60,000 children that we have worked on, and are likely to be publishing our coronary artery disease work soon. But diabetes, hypertension have been published, obesity is under review. Thank
Wonderful.
you.
So that clearly tells us don't give sugar even if the mother wants. Just try and ask her to do something else. So, but one more time, I would like to ask Dr. Manoj here that do you think that diabetes is a liver disease and several other metabolic things? So is liver the core for other metabolic diseases? What is your thought?
As Professor Sanyal has elucidated that fatty liver arises few years before the development of all these problems. First you have a fatty liver on ultrasound or other investigation, then you start developing hypertension, diabetes, then CKD, and then heart problems, etc. So why is this so? Because when liver gets inflamed, then it itself is acting as an endocrine organ. It is producing pro-inflammatory cytokines, even hepatokines. There was a new hepatokine like Futine, I have heard. So, and the pathways that are involved in producing all these problems, kidney, liver, heart, they are common. So, hepatokines, cytokines, and endothelial dysfunction related pathways, they are all converge and then produce all these liver and extra liver problems. So I think liver should play, and it should be considered as a primary driver rather than as a
primary driver.
secondary
So
driver.
I would have told Dr. Prabhakar that the title should be The Missing Link. He hasn't put liver as the missing link in the whole syndrome, so it should be the missing and the central core. I'll now pass on to the next question about the cardiovascular diseases, means heart disease, blood pressure, even peripheral vascular, and maybe even stroke and others. And I would like to ask Dr. Chawla that the major cause of death in patients with fatty liver is not the liver but other causes. So how do you explain that it leads to other complications, cardiovascular and others, with fatty liver?
See, as Arun had mentioned, the atherosclerosis becomes very common in patients with fatty liver disease. And because of the cytokines, there is injury to the blood vessels of the entire person. So coronaries get affected, carotids get affected, and there are enough studies to show that the intimal thickness, especially of the carotids, goes up. And that probably would be also true for the coronaries. There is increased calcification. There is some amount of fibrosis also which goes on in these blood vessels, and that possibly leads to all the...
So how should we screen these patients in practice? The patient comes with fatty liver or MASLD. Should we screen him for heart? Should we screen him for carotid Doppler? What should we do for him?
See, ideally, there is a risk score, ACSVD, by the cardiologists, which gives you a prediction 10 years hence whether the person will get any cardiac-related issues. So any patient with fatty liver who comes to us, we do a FIB4 and go and do that, the cardiac risk score also, which unfortunately we as hepatologists are not doing. It takes a little bit of time with the number of patients that we have.
So
but
we have lack of awareness as well as lack of commitment to look into other organs. So this is the fault of all the liver guys.
Yes.
I agree with you.
So this, and FIB4, as Arun said, rising FIB4 will give increased chances of cardiovascular events.
Yes.
And same is true for kidney disease. Higher the FIB4, more is the chance of kidneys getting affected.
Before I leave, but I find someone very important sitting, Dr. Nikhil Tandon. Nikhil, I know you're in the audience and you could have been anywhere. What are your comments? Are diabetes people looking for liver? Are diabetes people looking for heart? Can you give him a mic, please, quickly? Professor Nikhil Tandon. I want to keep him engaged, the most brilliant mind around. Yeah.
Okay, thank you, sir. I think this increasing, both in terms of prevalence and it's then the interrelationship, it's clear that we need to look for whatever name we want to call it as, but the steatosis has to be looked at. I think increasingly it should be now part of, like we do an annual review for people with diabetes, whether it's a complication workup. I think it gradually, some form of screening. I'm not saying necessarily everybody has to have a fibroscan available on site, but there's some form. It has to enter the consciousness of the treating team that this is yet one more comorbidity in that, without going into a chicken and egg story as to which came first. It doesn't really make a difference. The point of contact is a point of contact.
But are diabetes people looking now for liver and for other things?
I think 2 or 3 things are generally the awareness is improving. I would definitely make a plea for FIB4 because, as you said, it's much more, it's easily doable, right? A lot of us were even before looking at just the enzymes, right? Which may not be appropriate because, by the time the enzymes start rising, it may be a little further down in the disease. But I think the important thing is to get this intrinsically part of an understanding that this is something which could be, and then define a referral pathway. I mean, then that
pathway
has to be defined so that, that you should do.
So do FIB4, all diabetics, and then define who needs to go here. But we have a kidney guy, Gaurav. What do you do in the US when you have somebody with kidney disease, and do you look into, I know it will be taken in the next session, but what is the connect between kidney and liver or kidney?
Yeah, so I think I agree with Dr. Tandon. It doesn't really matter with what came first. I think the relationship between the kidney and the liver here is bidirectional. So incident CKD associates with MASLD and vice versa. We just published a paper in KI Reports. It's open source. I invite you all to look it up. It just came out last month. And the concept we propose is that patients with MASLD should be screened with urine albumin creatinine ratios and kidney function with GFR and creatinine. And patients with CKD should be screened for MASLD, primarily starting with liver function tests.
We
and then
now work together. We do creatinine, but we don't pay that much attention. So the liver guy is at fault that we don't do that much for diabetes or that much for sugar or for kidney. And maybe the same is true. And there is a point of convergence that we should have together. Now, obesity is very common, and I think it is going to increase for another 20 years, except Japan, where it is showing a decline. Every other country is showing increase. My question to Professor Sachadev is that, many people are lean, they are not overweight, they still have fatty liver. And how do you explain that group of patients, and how should we screen them?
So I think an hour back, Dr. Arora said there is something called family ecosystem. So it's just not your genes, it is things you're eating and the other factors operating in a family. So there can be lean people, multiple people with fatty liver, and there may be people who are overweight and having fatty liver in them. Other aspect is gut liver, the gut connection with the liver. So that is another thing which is very much applicable for the lean people. So you have to understand there could be the gut microbiome or dysbiosis which is leading to fatty liver, and fatty liver leading later after say 10 years or 15 years to a more fledged diabetes and other metabolic syndrome components. So
suppose somebody has high cholesterol.
I would like to focus on the genetic component as well as the gut microbiome, which has not so far been discussed.
So suppose somebody is lean and thin and high cholesterol and triglycerides. For general, are these questions your questions or they are my questions? Are these questions of interest to you or no? So the question is, if the person is lean and thin and he still has, high cholesterol and triglycerides, so what do you think, central obesity or visceral fat vis-a-vis overall look like fat?
Yeah, it's a location of fat which may be critical in these patients. So it's not just overall fat, it's a location of fat.
So how do you test for the visceral fat?
So you need to have a complete body analysis, and the major organs like fatty liver has got association
maybe waist and hip. You think waist and hip?
Waist and hip is more important than BMI. And then there have been correlates of fatty liver with cardiac fat as well. So all those things need to be measured in these patients, particularly lean and MASLD.
So my message is to everyone, and I want experts to opine. One thing, if the platelets are less than 150,000, single factor, once, and good platelet, reliable, it means there is something funny. If it is less than 100,000, platelet low means it is, you don't need any other test. I think there is fibrosis or the liver is affected. Similarly, if waist is above 80 for a female and above 90 for a male, you don't need any expensive test. There is visceral fat. Do you agree with this, Dr. Chawla? Shalimar? You agree with this? So for a poor man, for a common message, I think platelets alone, if they can be done well, and inchy tape will be good enough rather than anything more expensive. I see many cardiologists also here besides Dr. Jagat. I have one more thing. How much is the major adverse cardiac event per year? Suppose somebody has fatty liver, will you say कि भाई तुम्हारा हार्ट का बीपी का प्रॉब्लम 10% बढ़ेगा, 20%, कितना बढ़ जाएगा एक साल में? If somebody has fatty liver.
So it will depend upon, if we talk about fatty liver, it's not every individual has a disease. I think that's very important. We're saying 40% of us have fatty liver disease. That doesn't mean I start screening everyone for, or everyone is at a risk for
who should be
cardiac
screened
event.
for heart?
Yeah. So I think a couple of points have come up from the previous talk. One is the FIB force, which gives you some kind of, okay, they have increased risk, but it's a huge numbers which will come up. Then again, if we can calculate some kind of scores which are there, which unfortunately we don't usually calculate, that could be one, another thing which we can keep in mind. These patients would be more at risk. And those who have, say, metabolic
so everyone who is
components,
fat is not bad, and everyone who is lean is not good. That is a very clear message from you. I would like to now slightly go into more details, scientific details, and I would like to ask Dr. Manoj, a patient has come who has mast cell and has probably kidney disease, early kidney disease. His creatinine is 1.2 and he also has fibrosis. How do you assess his risks for future?
So there are many non-invasive tests that we know. One is liver elastography. Fibroscan is one of them, one of the modalities of assessing liver elastography. Then FIB4 we already know. And then there are other non-invasive tests also. And they correlate very well with the advanced fibrosis or significant fibrosis in the liver. And we also know that as the fibrosis advances, the risk of developing other organs like cardiovascular, kidney diseases is also increasing. Even atrial fibrillation, structural heart diseases also increase with respect to the liver fibrosis. As fibrosis increases, all these complications will increase.
So we should do fibroscan or a liver stiffness. We should do platelet count. We should do FIB4. And what else?
And other organs like
kidney.
Urinary.
So all of us should become a complete physician rather than a specialist. So go back to basics.
So initially the term was metabolic syndrome. Then came cardiac kidney metabolic syndrome.
CKM.
And now it is liver cardiac kidney metabolic syndrome.
All right. Now, should we, in the same light, I would like to ask Dr. Gaurav, should we have basket trials? Means the trial is not just for decreasing obesity or not for liver, but for heart, kidney, liver. So all drugs should, in the metabolic scenario, be basket trials. What kind of a trial would you like to do?
I think the most recent trials have had endpoints across multiple organ systems already. So as an example, I showed the SELECT trial this morning as well as the FLOW trial, and they have included endpoints for the kidney, for the heart, and overall mortality. They have not had endpoints for the liver separately, but as secondary endpoints, liver.
So you will make sure you will make noise on behind of all of us.
Yes. So ultimately, I think primary endpoints will be hard to do in a single trial, but secondary endpoints can always be done and should be done.
Dr. Shalimar, if you are given the choice to do a good trial for kind of metabolic disease, what kind of trial and drug you will choose?
So, sir, as what you said about a basket trial, I think one, in the current day scenario, I would not only limit myself to the liver. I'll say is like when we're talking about metabolic, so that means we're talking about multiple organs. It's not, we're looking at, unfortunately, the most trials, because we are always focused on calculating a sample size. We're looking at one kind of outcome. But then that limits, because there are multiple other secondary things which can be looked at. It could be the effect on the lipids, effect on the hypertension, diabetes. So, and the drugs which are coming up, like the GLP-1s, which now have multiple effects, including those on the obesity part, the diabetes part, the cardiac part. So I think we need to integrate all of them rather than looking at each one of them as separate things. They do not exist in, and human does not, in a human, not a single thing moves on its own. It's all things are affecting each other. So we need to look at everything in totality rather than focusing on one particular organ as outcome.
If you don't tease me, I'll give you my opinion. All these drug trials are made for people who cannot move or who don't want to move, who want to be couch potato, watch, and somebody else will make their health better. So they don't want to exercise, the drug will make them exercise. Means their calories are burned without moving. Now we have 5-7 minutes. I would like to ask people, do you have questions to the panel? Please raise your questions, your concerns. How many of you have heard of Mounjaro? Raise hands. How many of you have used Mounjaro? Many people have used. And Wegovy or semaglutide, how many of you have used? So all these drugs are there. Do you have concerns? Do you have any questions on that? In my opinion, these drugs are meant for people who cannot move or who do not want. So let me ask now the question to Dr. Chawla. You have Professor N.K. Arora, the wise man. Yes.
Thank you. Excellent panel. My question to all of you is, the key issue is we are talking about MASLD. You have given a very key message that when we are looking at a MASLD, actually we should behave like a GP and look at all the organs. That's a key message. My question is, how do I prevent MASLD? Somebody having MASLD, and particularly I have in my mind what Anupam was saying, in the pediatric age group, because it's interesting. We were finding 1/4 of them have fatty liver, and that's what Shalimar is also telling, that 40%. So it's slight increase, but most of the damage is already done by that time. What is to be done to prevent that?
Yeah, I think we should stop the production line. No children. If the parents are unhealthy, no more Marutis are made. And I have one of a president-elect of the National Academy, Professor General Velu Nair.
No, thank you,
Velu,
sir.
your comments, please.
No, thank you, sir. I must say, what a wonderful panel and so meaningful. So we've all become actually now postmasters. The comprehensive physician, I heard in your lecture saying, at the National Health Services, a family practitioner manages diabetes, goes down right up to the nurses. And here we just heard the interlink between multiple organs, which we are now talking that we should integrate it. So coming to the diet, what Dr. Arora and Dr. Anupam did say, what is the role of, minus alcohol, that's not a diet. So if you talk of what are the dietary implications in our daily life, especially in a country like India, number one. Number two, the abuse of antibiotics, dysbiosis. And
absolute. No for antibiotics. Like you say, no for smoking, no for alcohol, no for antibiotics. Thank you. Very important message from General Velu Nair. I have two scenarios. There is a guy in America who comes to you. He is educated. He is a multi-billionaire tech guy. And he is like this. And what advice will you give him, especially on two things, lifestyle changes and on alcohol?
So I think we know that any amount of alcohol is bad at this point. So,
but also for kidney.
Also for the...
Definitely for liver. So listen, please. Alcohol, no for...
It's a mortality association, so the kidney has to follow the life. Yes. And then in terms of lifestyle, of course, 30 minutes 5 times a week is the standard recommendation for exercise. Dietary protein should be reasonable, but dietary carbohydrate should be low, which is what the endocrinologists say, the ADA societies say, we will prescribe GLP-1s to these patients for sure. It is very common therapy.
Do they listen to you? एक कहा हिंदी में कहा जान जाए पर वजन न जाए.
GLP-1 लेने के लिए सब तैयार होते हैं.
So how many of Americans listen to you and lose weight? Tell me.
Well, तो GLP-1 लेने के लिए
No.
तैयार होते हैं.
Lifestyle, not with drugs.
Lifestyle, no, nobody listens. You know, if you reach the
1%, 2%.
So there is a concept in psychology which I was taught early in my residency, which is once you hit the age of 25, new concepts are very hard to assimilate.
Yes.
So that's the key concept, that if you are trying to educate lifestyle to a patient who's 50 years old, they will not do it.
They don't listen, Americans. Do Indians listen, and especially the population you see, Dr. Sajdev, the general and the Muslim populations of Daryaganj?
You had a very good study on fecal microbiota transplantation in alcoholics. So same can be translated to
Yes.
MASLD.
We're very, thank you for raising. We, for all severe alcohol associated liver disease, we transplant the bacteria. We have done maybe more than 350 stool transplants from the relatives, and it makes a huge difference. So it is not you who drink alcohol, it is your bacteria who get addicted. So now we have just completed another trial of making stool transplant to prevent addiction, and it is a very, very encouraging. It has just yesterday got an oral in the easel, so we are very lucky. Now for my question to you, how do you make an Indian, rural or a Daryaganj guy lose weight? What do you do?
Basically, get them rid of their mobile phones. You see, the screen time these days, when we were children, I think we were most of the time in the evening in the parks for 2 hours, 3 hours.
Do they listen to you?
Nowadays, the parks are vacant. So there's nobody in the parks.
Very difficult
no kids.
to
So
lose weight. Very.
this is for Dr. Sibbal. I think children are the main.
Everyone listens to him.
Yeah.
The whole country listens to Anupam.
The lessons have to start from very early childhood.
Anupam, what's your
outdoor
way of handling and getting things done in the kids?
Screen time needs to be reduced.
Absolutely. I mean, I just want to elaborate on what Velu said, and I think Velu talked about the diet. I think we need to go back to the Indian thali. You know, it's just so irritating when parents say, oh, but Friday is a cheat day for the child and he can have junk.
All your parents, do you all tell your children Friday is a cheat day?
Right? So we need to move away from this, go back to the traditional thali, embrace that. There are lots of parents here, there are lots of grandparents here. Please, it's extremely important that we get the dietary habits right. Gaurav talked about changing at 25. I say it's very difficult to change at 15. So you have to get the fundamentals
right. So last minute message from each one of you, because we have cheated on time.
Can I give one small comment?
Yeah, please, Dr. Narula.
I was just thinking about what Dr. Sibbal said. 24% of the children 9 to 14 years of age who had the fatty liver. PB Day study, that famous study, 10 to 14 years of age, 50% of them had fatty streaks, right? And you go from 14 years to 34 years, 70% of them have it, and they are all reversible. So it has a big message.
So plaques in the heart can be reversed if you reverse their mindset. And mindset is very difficult. Last 1 minute, half-minute message from each one of you. We have cheated on times of Dr. Prabhakar.
So my advice is to my patients is cut down anything from packets.
No, the core, liver is the core. On that is liver seminal in the pathophysiology of cardiometabolic conditions. Your message on this?
I think so you already emphasized it is the core. I would agree.
Any other message? Liver is the core. Love your liver. Next.
I think we need to have campaigns of fatty liver. Like you have campaigns of tuberculosis.
So Sitaram Jaipuria Foundation has work for next year.
Yes.
Very good. Thank you. Anupam.
Start young.
Start young. So
start with pregnancy.
Start with pregnancy. Sitaram Jaipuria Foundation to listen. All right. Thank you. All right.
I think awareness is the key. Public awareness, even awareness about from general physicians and for children.
Very important. General physicians, even 5% do not know. Fatty liver है क्या है? उसके भी है यार चल ठीक है.
So liver is the foundation stone for all these cardiometabolic diseases. Change the foundation stone.
Very good.
My point is to check urine albumin creatinine ratios in all of your patients and think about the kidney failure risk equation, which we talked about. It's a very important concept to determine the risk of kidney failure in the patient.
So urine is just not a excreta, it is protein in the urine should be checked and all. Well, 27th of May is the Sitaram Ji's birthday, and we hope that in next 2 months we should have some campaigns and work around, and I can see Ashok sitting there, so we should have some. And thank you all for being partner to this panel discussion, and thank you all.